Hey guys, my name's Steven. Today we're going to be covering Ocular Basics, so let's get started. First thing is we're going to be choosing the linear probe for this exam, and that's because this is the high frequency probe and it can really help us identify these small superficial structures well. Now, ocular ultrasound is a little different from the rest of the scans we do, so the setup might be intimidating for some people, and it might actually be a reason people don't do this ultrasound. So it's actually fairly easy, and I think that we should all be encouraged to try it at least at some point so that we get comfortable with it. I prefer this tegaderm method that's represented up in the top here. This is an image from Core Ultrasound, and they put the tegaderm on here, and then all the gel goes on top of that. So this makes it easy for cleanup, and it makes the patient a little more comfortable, in my opinion. The other method that is described is basically just having the eye closed and putting the gel right on top of the eyelid, which I think is a good method as well. I just prefer the tegaderm. So after you've put a sufficient amount of gel on top of that tegaderm, you're going to want to image the eye and make sure you get a nice wide view of the entire eyeball. So basically this is what you should be looking for. And the way you want to do that is fill that cavity area with as much gel as possible, and then lightly set the probe there and slide up and down in the area until you get a view where you can see the eye basically as big as you can. Now the anatomy you're going to identify here kind of consists of a couple things. The lens, the posterior segment. You're going to want to check this entire posterior area here, which contains the retina, the choroid, and the sclera. And I think that's something we sometimes forget when we're doing ultrasounds, is that there's more back here than just the retina. And then finally, you're going to want to identify the optic nerve. So let's look at this next image. So see what you can see here. At the top of the image, we see that lens right there. You see that bright white line that represents the posterior segment of the lens. You see the iris here, and here's the anterior segment, and then here's the posterior segment once we fan back, kind of nice and anechoic. And that's how you should be looking at the retina there. You see this person is fanning back and forth. So what you want to do is you want to put the probe on the eye, fan back and forth, and then rotate and fan a couple more times so that you can really see all areas of the retina, closely observing that back wall for any sort of irregularity, because any bump or any fluid collection back there could represent pathology. Now, after you've kind of fully evaluated the retina, the next thing you want to do is check that posterior segment for any sort of hyperechoic material that could represent a posterior vitreous detachment or a vitreous hemorrhage. So the key in not missing anything here is having the patient move the eye and slowly increasing the gain. So you see in this clip, the gain is fairly high. We have a lot of extra gain out here on the sides. And so basically what we're looking for is this spinning stuff in the back of the eye. All that stuff that is supposed to be in the anechoic posterior chamber is now hyperechoic, and as you can see, it's very mobile when we have them move the eye. So put the probe kind of right in the middle where you can see a good segment, and slowly increase the gain as you're having the patient move their eye back and forth for you, and this will give you that nice, bright, swirling stuff in the back of the eye that usually either represents a posterior vitreous detachment or a vitreous hemorrhage. Now, the last thing I want to discuss is measuring the optic nerve. And so if we have an optic nerve measurement more than 5 millimeters, that actually has a sensitivity of 90% and a specificity of 85% for an ICP greater than 20. Now, the regulations or the recommendations have kind of been updated to look for an ICP greater than 25, but nonetheless, I find that this works pretty well, and there is a good amount of literature suggesting you can actually use ultrasound to track the progression of intracranial pressure in the unit and things like that. So the way you measure it that you have to remember is that you go 3 millimeters back from the retina, and then you measure from each of these little lines over here, like the walls of the optic nerve. And the other thing is having it in the correct position. So as the eye moves, the optic nerve will obviously kind of change orientation, and you want to measure it at the point where the two walls are parallel to each other. If they're at an angle to one another like this or like this, you will probably get a falsely high or low measurement. So you want to find them where they're parallel. And the way to accomplish this is kind of find the nerve and then have the patient look around the room to the point where you can see those two walls parallel to one another. And really that's it for ocular ultrasound. It's a fairly easy exam, and it's really great because we don't do many dilated fundoscopic exams in the ER, and it can really help us portray some of these pathologies we're worried about to the ophthalmologist on call, instead of just saying, they have some floaters and I'm not sure what it is. So get out there and ultrasound some eyes, guys.